Hi, it's Dr. Noel Williams, Optimal Health Associates, Oklahoma City, Oklahoma. COVID update, December 6, 2020. Looking at the numbers, I think we've had 9,000 cases in 2 days. By the World Meter website, it's sometimes hard to tell, but our case numbers are going up, unfortunately, as expected from Bedlam and Thanksgiving. So that's going to be problematic because you figure about 10% to 12% get hospitalized. Third end up in the ICU. We're down to one ICU bed at 7 o'clock this morning for the entire Integra system throughout the state. There's been problems with transferring people just because the ICU beds are so full. There's still some hospital bed availability, not tons, but at least beds here and there. But the ICUs are pretty full. The ECMO machines are full. We're now getting to the point of saturation. We probably have 1 to 2 weeks before we really are going to be in a more troublesome situation where there's really going to be difficulties with picking what you're going to take care of, unfortunately, at the hospital. Now, elective surgery, let's talk about elective surgery for a minute. Elective surgery isn't the right word. If you have cancer, it's not elective. If you have a big ovarian cyst that's killing you, that's not elective. If you have profuse bleeding from your colon or moderate bleeding from your colon or your stomach, that's not elective. Those all, though, are elective in terms of what they're defined as now. People sometimes think elective is like plastic surgery. Yes, that is truly elective, but that isn't what we're talking about. So changing that won't matter. Outpatient certainly doesn't matter. Inpatient really doesn't matter because that's a very nominal amount of beds. So
I think that was confusing. You're saying that those things that you listed are under the umbrella of elective.
Yeah, they are all elective. The only thing elective means is it's not an emergency. Think when you hear people talk in a governmental situation about elective surgery, it means it's non-emergent. So if you have appendicitis, that's an emergency. If you have cancer that in your body, that's not an emergency. If you have bleeding that isn't going to kill you, that's not an emergency. If you have a broken bone that if it isn't set right now, you end up deformed, that's still not an emergency. So that's the problem with using the word elective. 90% of the surgeries we do are quote unquote elective. I mean, when we went through the block on surgeries in April, May, I mean, I think I did 2 surgeries in 2 months, and normally I would have done about 45 or 50 in that period of time since I don't do as much as I used to. But I did 2. None of the other ones I'm doing are elective. They're all people with either ruling out cancer, they're bleeding too much, they have pelvic pain, they have problems, they have ovarian tumors, but you can't do that. By that definition, we couldn't do them. So that's the problem with banning elective surgery. One, it doesn't open up hospital beds, which is the important thing. Last time what happened was we didn't have PPE, we have PPE, so there's not an issue with that. So we want elective surgeries to stay open. The problem is the wave of patients. It's too many people getting sick. It's simple economics. You know, economics is the study of infinite need or want and finite resources. This is where we are with healthcare. Too many cases, not enough beds, not enough doctors, and way too few nurses. So again, if you know a nurse, be nice to a nurse. There's more of a nurse shortage than any other thing. It is a nurse shortage crisis and a support staff crisis. It is not, I mean, the doctors are there. I mean, sure, they may be overworked, but nothing compared to the nurses. Be nice to nurses. Give them, if you know a nurse, be nice to her. Give her chocolate or a flower or something. Tell them thank you wherever they are. The ones who are taking care of the COVID patients, all the ones everywhere. We have a massive nurse shortage, and we're feeling it right now. So that's really the main part of what I wanted to talk about. So what do you need to do? You need to take your vitamins. You don't want to get sick, take your vitamins. If you get exposed to the zinc pulse, which I've gone over 400 times, you know, it's basically getting 150 milligrams to 200 milligrams over 24 hours, 30 to 50 milligrams at a time with food. So I've listed that out many times. And so it is what it is. You should be on your vitamin D. You should be on your fish oil. The fish oil is more important than ever because all the blood clot stuff that's going on. Fish oil helps block that. You need to be on your melatonin. You need to be on your multivitamin. There's other things you can add, but your core stuff, multivitamin, vitamin D, fish oil, melatonin, and zinc. And once you've been on zinc for about a month to 2 months, you go to every other day. You have to take zinc with food. The pediatric doses I've gone over a ton of times, but remember, pediatric patients don't get that sick with COVID anyway. So Flintstones for the kids. That's all I ever say. So that's what we have to focus on. Stay home. The CDC just came out with going to big box stores is about the most dangerous place. I don't know if that's true, but it's certainly the data is pointing that way. Number two, trying to avoid restaurants with groups would be great. Again, if you have to do a business thing, you can still do it if you need to, but really be selective on what you're doing. Holidays, small groups like we were supposed to do at Thanksgiving. Follow the CDC guidelines as best you can. Obviously, I'm a mask person. I think masks are important. Even if it just lowers the infective rate by 5%, that's a huge number. But I think it's better than that. Obviously, it's probably about a 50% reduction in infection. But that's about it. I mean, it's a disaster. We're not prepared in the United States. We're not prepared most of the rest of the world, to be honest. And when you have these one-off countries like New Zealand that are doing better, remember they have a very small population. They're homogeneous and they basically have no independent decision making. So, which is for COVID okay, but maybe the rest of your life it's not. So it is what it is, but we need some guidance. We want guidance from the government and some limitations from the government. The Oklahoma City Mayor Holt, put out his policy of limitation. All great stuff. That's what I would urge everyone to follow. So what questions do you have, Kim?
You had wanted to talk about wearing the mask correctly and why that's important.
Oh, yeah. Well, having the mask below your nose renders it ineffective, okay? This is your nose, so nasal. So everyone knows what their nose is, nasal. And then back here, in the back of your nose, on the inside is called the nasal pharynx. That is where the virus really gets going. So breathing it in through your nose is probably the single worst thing you can do. I'd rather you just had your nose plugged and your mouth open than didn't cover your nose. Every time you see someone not wearing their mask over their nose, think, oh, whatever word you want to use. They can infect you and someone else could infect them. So no, you have to cover your nose. So any pictures of people not wearing the mask over their nose, well, they could get infected.
Okay, so questions. Roughly how many COVID patients have you personally treated and how many about those have been hospitalized?
So we've probably treated somewhere between 110, I would guess, maybe 100, 110, max 120, 125. We've had one person hospitalized for COVID. We've had one person hospitalized not knowing they had COVID, but they got a secondary pneumonia a couple weeks after their initial infection. So that's what we've seen so far. But I mean, we treat everybody, so it's a little different. I mean, we're getting the numbers we would expect. The hospitalized patient, again, was a misadventure in steroids. When I ordered them, they weren't at the pharmacy. She was doing better, but her lungs were getting worse. And so she ended up going to St. Anthony's where she got some dexamethasone and did great. And a big shout out to St. Anthony's. And then my other patient got a secondary pneumonia when he was out of town. And when he flew back, he went right to St. Anthony's and they took care of him then. So they both couldn't say enough about St. Anthony's. But I think, again, as I've told everyone, Saints, OU, Mercy, Norman, Midwest City, and Integris are awesome. You can't go wrong at any of those facilities.
Have flu cases gone down?
I haven't really been paying attention, so don't know.
Okay. How long after you receive the vaccine is immunity reached?
So immunity with an RNA vaccine, it looks like it's going to be with the Pfizer one 7 days after the second dose. About 90% of people are going to be immune. Number two, it looks like the immunity may last a little longer than originally thought. There was just a paper out today I received, but I just glanced at it. So we'll see. We'll see. I think ultimately getting the infection is the most effective way of having long-term immunity. But again, unproven, I know, but let's be honest for a second. If you were symptomatic and got the infection, your neutralizing antibody programming is a heck of a lot better than a vaccine's. But, the proof will be in the pudding, but that's what I'm going to go every time with. But the vaccine looks really good in terms of short-term stuff. The big question is, what does a messenger RNA vaccine do long-term? We don't know, but if you're a first-line worker or a healthcare provider or a high-risk patient, you're looking at getting COVID and several percent death rate. So, I think you go with getting the vaccine. If you're super low risk, you've already gotten it, I think you delay your vaccine, but that's my opinion. That's a personal opinion and a personal and a professional opinion. It may disagree with other people, which is totally fine. We're allowed to have different opinions. But if you're a 14-year-old, do I think you should get a messenger RNA vaccine with no long-term data? Heck no, that's stupid. I'm sorry. The risks are greater than the benefit. So that's my opinion for what it's worth.
Okay, so you talked about this a long time ago, but it's been a while. So somebody's asking about Cytokine Storm with Elderberry.
So I don't think Elderberry so much inhibits Cytokine Storm. Cytokine Storm's an inflammatory pathway that gets turned on with COVID. Elderberry is more an antiviral. So to kill the COVID before you actually get the cytokine storm. Cytokine storm is inhibited by higher melatonin levels, human growth hormone levels, probably also, obviously by Plaquenil a little, also by fish oil, and potentially by a multivitamin.
So is it safe to
and vitamin D.
Is it safe to take the Elderberry if you're positive?
Oh yeah, it's great. No, it's an antiviral. Okay. Definitely safe.
Okay. If people are taking bioidentical progesterone, does that raise the risk of blood clots with COVID?
No, bioidentical progesterone has no effect on clotting parameters, period. Okay. Any route of administration.
Okay. So for people that have had COVID and recovered, this is a multi-part, but it all kind of ties in. How long is immunity? You've talked about that. Can you get it again? How long are you immune? Can you spread it to other people?
So I think the bottom line is, if you've gotten COVID and recovered, it is incredibly unlikely you're going to get COVID again within the next 6 months, period. There's no data to support you're going to get reinfected at all. It's a fear. That's how medicine works. That's how people get manipulated. It's a fear. There's no data to support it. These one-off cases are meaningless. You need to be concerned if there's a cluster of 30 or 40 people in a community that have gotten COVID, then they all get it again. That's a true variant. If that happens, then we have to be concerned. Until then, that's my opinion. I'm sticking with it. It's basic immunology. It always works better to get the infection than a vaccine. That is 100% of the time. Tell me, I want anyone to post something where getting the vaccine is better than getting the infection for immunity. Okay? Not that I want people to get infected, but the whole reason we give vaccines is to avoid devastating infections. But if that's the problem with COVID, if you've already gotten it, your B cells, your B lymphocytes are programmed to defend you. So again, I think it's very unlikely you're going to get it anytime soon. I think the CDC generally agrees with 3 to 6 months. I think it's probably much longer than that. Number two, can you spread it? Well, if you can't get it again, you can't really spread it unless it happens to be on your clothes. So if you're a healthcare worker who's already gotten it and you're working in a hospital with COVID, you need to, when you get home, take your clothes off, put them in the dirty clothes, and take a shower immediately, because the COVID could be on your skin, it could be on your hair, it could be on your clothes. So I think that pretty much answers that, I believe.
Yeah. And then how do you feel about ivermectin for outpatient treatment?
Ivermectin for outpatient treatment is purely experimental. It's experimental. I don't know what to tell you. I think there's less data on ivermectin than Plaquenil. So, but I think ivermectin would be fine. It's harmless if you take one right when you get COVID. I think it's totally harmless, and it may work, but who knows? But ivermectin is harmless unless you're allergic to it, which is like hen's teeth. So pretty unlikely.
One last one, and you probably won't know, this is probably more opinion. As a healthcare worker, if you've already had COVID, would you still be required or expected to take the vaccine?
I have no idea what they're going to do, but my guess is they're going to try to make everyone get the vaccine, including the people who've been infected already, which makes no sense. So I think minimally you should get the vaccine if you're a healthcare worker and you haven't gotten it, you're a high-risk patient and you haven't gotten it, you need to get it right away. Now, if you've already gotten it, you could eventually get it, but you would be at the end of the line anyway. You're the least important people to vaccinate. So that's my opinion on that. But I'm an outlier again because I don't believe that doing a vaccine on people who've already gotten something makes sense because we have a limited amount of vaccine. Let's use it on the people who need it most, the people who haven't gotten infected. And then as this settles out and we see more and more data, if there's then vaccine that could be used or excessive vaccine and we can start vaccinating people who've already gotten it, then that becomes a debate. But at first, it's the single stupidest thing to do is to use vaccine on people who've already gotten it. Thank you. Good night.